Welcome to today's webcast. This is going to be a great synthesis of some of the top abstracts at ACR 22, which we're still kind of recovering from. I don't know how many of you who are listening in were there. It was a great experience. It was kind of like learning to ride a bicycle again. It wasn't totally natural to be with so many people, but it was enjoyable on that respect. A lot of data, and I've got a great group of comrades, Laura Coates from Oxford, Sophia Romero from Leiden, to join me talking about RA, PSA, and SPA. So without much further ado, I'll give you some housekeeping thoughts. So all the attendees will be on mute for the duration of the meeting. Questions to the speaker can be submitted anytime through the QA function, so we'll try to keep track of that. If you're having any technical difficulties, just shout out in the chat box and we'll get back to you on all of that. So here's the lineup. We're going to start with RA. We're going to go through PSA and axSpA, and after each section, we're going to have an opportunity to do a little interaction for a few minutes and discuss whatever is on your mind. We're going to cover a lot of abstracts, so the granularity here is going to be low, and we'll just try to hit the high points, and if you want to go back, the abstracts are obviously accessible. So I'm Len Calabrese, I'm a professor of medicine at the Cleveland Clinic Lerner College of Medicine in Cleveland, Ohio, and I'm going to dive into RA. So first abstract, baricitinib improves bone biomechanics in RA, prospective interventional study. So this is kind of interesting, and this is really foreign space for me. So, you know, we know that preclinical and clinical observations on JAK inhibitors have had a positive effect on bone, but no prospective interventional clinical studies has evaluated bone strength. So this is called the Bare Bone Study. I love the name. It evaluated changes in radial stiffness and strength using techniques that I really am not very familiar with, but I did a little background reading on them, very sophisticated, and have strong clinical correlates. And essentially, over a 48-week period of time, there was an improvement in mean failure load, which is a threshold for fracture, and mean radial stiffness, which has been correlated with same type of events. The numbers here were statistical, but you know, don't have a lot of face validity to most of us. Also, a decrease in cortical porosity was associated with a larger improvement in failure load, which seems to make intuitive sense in terms of bone. The bottom line of this study is that baricitinib rapidly and significantly improved failure load and stiffness of bone while reducing structural cortical porosity. So this is only over a year of a lifetime of disease. So I take this as a provocative abstract, and long-term studies obviously will be forthcoming for this. So let me. So the second study is the impact of going back here. The impact of upadacitinib versus abatacept on individual disease outcomes. I'm going to go back and switch this back. So UPA versus ABBA effects on individual disease outcomes in patients with RA, and inadequate response to biologic DMARD. So everybody's kind of familiar with select choice trial in RA, prior inadequate response to biologic DMARDs. And there was a comparison between UPA and abatacept. That demonstrated that there was superiority of upadacitinib in terms of change of DAS-CRP, and a portion of patients achieving low disease activity at week 12. So this was a post hoc analysis of that same study looking at individual components. So, you know, there's a lot of intuitive results here, but I think it's nice to see. So at week 24, there were a similar proportion of patients receiving upadacitinib and abatacept achieving greater than 50% improvements in all but the high sensitivity CRP, which was superior in upadacitinib. Overall, 15 and 26% of patients on UPA compared with 16 versus 15, so numerically less, on ABA demonstrated more extreme outcomes, greater than 50% improvements across all ACR components. At week 12 and 24, Boolean remission, rigorous remission, was achieved by 6 and 14% of patients on UPA versus 2 and 10 on abatacept. And then the cumulative distributions of other markers, CDI, SDI, DAS28, high CRP, and ACR-N were improved on upadacitinib versus abatacept, though all nominal, considering how many comparisons. So the bottom line of this study, which originally showed superiority of upadacitinib to abatacept, showed that at week 24, there were still nominally higher attainment of Boolean remission and its components with this therapy. So next abstract is RA, who switched from adalimumab to upadacitinib, demonstrated a robust reduction in inflammation-related biomarkers. This is a proteomic analysis. So if you actually go back and read this abstract, there was a complex matrix of over 30 biomarkers that were examined. And basically, they asked the question, was that, you know, in patients who were on this comparative study, if there was a track to switch patients at week 12 from either methotrexate or upadacitinib, depending upon outcomes. And then this analysis looked at biomarkers in these patients who were suboptimal responders. And the bottom line was, of these 31 biomarkers, there was a much more robust and expansive influence of upadacitinib switching than adalimumab switching. And so there was differential expression, and you can go through this. Many of these are well-known biomarkers. Other were pathways that are not familiar with us at first glance. And, you know, my takeaway from this is somewhat muted. You know, we're comparing a drug that targets a single cytokine versus an intracellular cytokine hub for over, 50 cytokine type 1 and type 2 cytokines and chemokines. But it also underscores the power of JAK inhibitors in modulating the integrated immune response. So I will be happy to address any questions on this at a more granular level, but that's how I took away from this. So this next abstract is on the safety and efficacy of upadacitinib in patients with RA and inadequate response to conventional synthetic DMARDs. This was the Select Next study, but this now examined it through 5 years. And, this past year has been the year of, confocal attention to toxicity of JAK inhibitors, which has led to major relabeling on both sides of the Atlantic. And so these type of long-term studies are important. And although they're flawed by design and dropout, the power of them in terms of patient years makes up for that. So clinical outcomes continued to improve or were maintained through week 260. And here I show the numbers showing a stronger response to upadacitinib 30 versus 15. At week 260, over half the patients achieved extreme endpoints of ACR 70 on either dose. And then when looking at component measures, physical function and pain, it was somewhat similar with 15 and 30 milligrams. In terms of adverse events, including serious adverse events, as well as minor any infection, and then events of special interest, including certain cancers, zoster, et cetera, they were observed with greater frequency with both doses of upadacitinib versus placebo. And while malignancies were rare, numerical rates were higher at 30 than at 15. So, you know, upadacitinib with background conventional synthetic DMARDs demonstrated sustained efficacy across multiple disease activities, 5 years. And it gave us a little hint about toxicity, which we'll see in more detail moving ahead. This is safety and efficacy of upadacitinib in patients with RA and inadequate response to biologic DMARDs now, a more rigorous population, a higher bar to cross. And this is the Select Beyond study looking at 5 years. So these are patients that were intolerant or non-responders to one or more biologic DMARDs. They got 15 or 30 of upadacitinib, and then looked at efficacy and safety of these doses up to 5 years. Again, these long-term extension studies are powerful because of patient years, but are limited because of dropout. And even though there are techniques that are looked to dampen these technical pitfalls of such studies. So with both UPA dosage groups, patients demonstrated similar clinical improvements over 5 years. And now these are patients that are still on therapy, but these results are, you know, still impressive. That, you know, 30 and 36 and 80 and 1 and 77 on 15 and 30 were still in CDI remission or low disease activity. And if you looked at ACR responses of 88, 68, 51 for 20, 50, and 70, and then 88, 67, and 46 at the higher 30 milligram dose, even more impressive. Functional and pain outcomes were similar with both 50 and 30, which I always find interesting. No apparent loss of benefit was observed at 15, who switched from 30. And then, as expected, there was dose-dependent increase in certain toxicities, including zoster and the CPK-emia seen with mini-JAK inhibitors. No new safety signals were seen. So this is looking at the association between short-term response to upadacitinib treatment and long-term clinical outcomes in patients with RA who are TNF failures to begin with. You know, this is a common clinical question. You know, how long do you need to keep a patient on these drugs before you pull up stakes and think about switching? And this actually, attempted to look at this. So they looked at the response in the Select Beyond and Select Choice studies at weeks 4 and 12, who failed to achieve a CDI improvement greater than 6 from baseline. And then asked the question of those that didn't respond, who was likely at week 48 to achieve low disease activity or remission. And the results are fairly sobering. You know, if you didn't achieve a clinical improvement of CDAI by week 12, your chances of being in low disease activity of remission were 6% and 0 at week 48, regardless of dosing. On the other hand, I'll extract from this and bring to your attention, week 4, you know, there's still some chances of getting some high-grade response. So depending upon how refractory the patient there is, you know, 4 weeks is not a good sign of not being responsive to these drugs because they work so quickly. But this may be a point of shared and informed decision-making to give it a while longer. But at week 12, it's pretty clear. And, you know, you can look at this abstract in greater detail, but that's the bottom line, which said that most patients achieved early improvements in CDAI and DAS-CRP with upadacitinib. And if you didn't improve greater than 6 CDAI or 1.2 DAS-28 CRP within 12 weeks, you're unlikely to benefit over a more prolonged and desirable period of time. So filgotinib, interesting drug. You know, we don't have this over in the United States, and you do have this in Europe, so we don't really have much experience with this. And as with all JAK inhibitors, there's a greater focus, as I mentioned earlier, on toxicity. So there was some suggestive data at the 200 milligram level that patients over 65 had more serious toxicity. And so this is a post hoc analysis of phase 2 and phase 3 clinical trials of exactly that group, and then doing some detailed epidemiologic comparisons between greater than and less than 65 years of age. So the results of this are not surprising. One, if you compare 65 older to less, yeah, these people have different risk profiles. They have more cardiovascular risk at baseline. And even when they did these adjusted analysis of these adverse events of special interest, they were still generally higher in patients greater than 65 versus those under 65. And the adverse events of special interest that were seen included MACE events, VTE, serious infections, and zoster. While there was not statistical difference, there numerical more frequently seen in the higher dose. Despite the fact that the clinical responses were maintained, these toxicities, you know, have to be looked at, with a different lens right now. And so labeling of these, this drug as a class, which I said in the United States doesn't include filgotinib, says, you know, special attention to people of older age, whether it's 65, 50, or 55, and a careful examination of underlying risk factors and risk-benefit analysis before using such drugs. So next, abstract 0272, long-term efficacy of BERA in patients with RA with inadequate response to biologic DMARDs, results from RA beyond up to 6.9 years of treatment. You know, my special interest in biologics is safety, particularly infectious complications. And, you know, I really like to see these studies that rack up the patient years. So the very robust baricitinib program, RA Beacon, or biologic incomplete responders were randomized to 4 and 2 milligrams of BERA versus placebo. Recognize in the United States, we don't even have 4 milligrams. And then completers to week 24, if so you made it, you had some response, then they could continue on 4 or 2 up to 360 weeks. And then looking at long-term efficacy was reported. And again, these long-term studies are limited by their design of people who will stay in these studies, but the results are still quite important. If we looked at low disease activity or remission, these numbers are quite impressive. 47%, 70% with 4 milligrams and 2 milligrams with baricitinib 4 and 2 milligrams at week 156 and 360. And then remission, 15 and 26%, 26% even with 4 milligrams and 2 milligrams at week 156 and 360 respectively. And similar improvements in quality of life measured by HAQ-DI. So, JAK inhibitors, while we wring our hands and are learning to parse risks across the board for all these JAK inhibitors that we're seeing, maintaining efficacy and normal physical function for up to 6.9 years are quite reassuring. This is an interesting abstract. Pain and treatment switching among patients in the core Evitas RA registry. So this is a robust registry that they mined to explore the association between patient-reported pain and switching to biologics or targeted synthetic DMARDs. We talk so much about tender and swollen joints and CRP, but when we talk to patients, there's a different agenda. A day without pain, a day without fatigue, empowerment. And so this drilled in on pain. There's a lot of patients, 7,800, 9,500 on biologics or targeted synthetic DMARDs. And a higher proportion was severe pain versus mild pain, reported greater than 2 previous biologic DMARDs, as well as the use of opioids, which is really sobering here. 49% had used opioids, and also consistent with a higher use of prednisone. And the unadjusted risk of switching biologics targeted synthetic DMARDs was 2 times higher in those that had severe versus mild pain. So pain counts. That drives the patient to say, I'm not satisfied. And there are other metrics that you can examine in here. But collectively, these findings suggest that persistent pain is common in RA and influences treatment decisions, particularly a switch to a different MOA. And I'd be happy to field questions about this, because that these patients with RA who have both nociceptive pain, chronic inflammatory pain, but are also subjected to nociplastic pain in a very high percentage of patients. So just paying attention to pain is an alert and makes us want to dissect it a bit before we start continuing to change our drugs. So this is a large study from France, OPAL data set on real-world utilization and switching between JAK inhibitors in patients with RA. So we've had JAK inhibitors a long time. New ones are being introduced at a rapid pace. And so, I'm sorry, this is an Australian OPAL data set. This is 5,900 patients describe time to switching patterns, concomitant conventional synthetic DMARDs, and reason for switching, who had initiated TOFA, BERA, or UPA as first-line, second-line, or third-line therapy, and subsequently switched either to another JAK inhibitor, TNF inhibitor, or another biologic DMARD. So a lot of switching going on here. But there are a couple themes that I'll just point out to you. Persistence was comparable across all these drugs. And consistent with what you would think, if you were on your first JAK inhibitor, you were more likely to stay on it versus patients receiving another JAK inhibitor or JAK inhibitor as a second-line therapy. So you've already been identified as a refractory patient. JAK inhibitor to JAK inhibitor was now observed in this study. And, you know, that was a big question for a long time. For many years, we only had one JAK inhibitor. Then another one came out. We were reluctant to do it. But when we start switching JAK to JAK, it's usually in people who have limited options. Early in the first switch from a JAK inhibitor often was to another biologic DMARD or a TNF, but later switches entered in the option of JAK to JAK switching. Lack of efficacy was the most common reason for switching, but a small percentage of patients who initiated JAK therapy did report an adverse reaction. So this really isn't a guidance for therapy, but it kind of gives us the pulse of what clinicians are doing with JAK inhibitors in patients who don't have this. All right, so we've reached our end of our time. I just basically made it. Going to open this up and take some discussions from here. So Laura, Sophia, any comments? What was your biggest surprise or most interesting abstract from there?
I think it's useful to have more of that data on switching and to know a bit more about what people are doing, and that's something that seems more of an issue as time goes on, that we're well aware that we have quite resistant patients often who've not responded well to a first drug, or for whom it's worked for a while and then we've lost response. I think it's really useful that we're seeing more studies looking at how you switch from one type of drug to another, whether you can cycle within a class, what the best outcomes may be with switching, because I think that's a big question that bothers us in clinic day to day.
Yeah, I don't have much confidence in my JAK to JAK switching, which you do when you have to, but it's nice to see some data. Sophia?
Yes, without wanting to say exactly the same as Laura, I wanted to emphasize the same abstracts for clinical practical reasons, that indeed though that is the information that we are needing, and it's very unlikely that we will have all those trials with all those possible combinations between patients who have failed a certain drug class and we'll have another one. So observational data become even more important in that. Although I think it's also important to emphasize, we're all aware of that, but confounding by indication becomes a problem, because what are we comparing? Are we comparing something comparable? Are different types of patients being switched or being started in a JAK inhibitor than those that are started on a TNF inhibitor? And I think it's important to take that into account when we are interpreting these studies. It remains challenging.
Yeah, please, for the audience, throw in your questions while we're chit-chatting.
Yeah, I was going to say that there are two questions from the audience. I don't know if you have seen.
I can't see them.
I can read them. So the first one is, it's about abstract 0304. So what is the significance? Is it a greater proteomic response more desirable than targeted TNF proteomic response?
That's a great question. I have not heard that abstract presented, but as I said, at first blush, this is not surprising to me. I mean, I think you are mandated by the underlying biology of a single cytokine inhibitor versus an intracellular signal transduction inhibitor having a differential biologic response using at least one form of deep immunologic profiling. I think it belies the power of this class, whether that is always desirable or whether that shows potential for off-target effects, I think remains to be seen. I don't know if either of you saw this abstract, but any thoughts on this?
Well, I hadn't seen the abstract. I heard your summary around it, and I think it's very interesting, but I think it's still preliminary data. I think we need more research on this before we can really make use of this in daily clinical practice.
Yeah, I mean, hopefully moving forward, biomarkers like this would be able to help us maybe select the best drugs for different patients or work out how best to move forward if somebody's failed a medication. But unfortunately, we're still a way away from that, aren't we?
I think we have.
And I agree with that. And I'm sure that the investigators of this trial are looking at those biomarkers that move the most in those that responded, and now, post hoc trying to go back and look at baseline biomarkers to see if there was any prediction. But this is just the first cut of a very complex data set in a very small group of people.
And I think we have been. Yes, we have another question, and I think it's in another hot topic, as you have mentioned several times in a presentation, namely safety of JAK inhibitors. And the question is, can we apply generalization to avoid JAK inhibitors in older males above 65 years old, especially in patients with atherosclerotic cardiovascular disease?
You guys want to jump on that?
Well, I think it's the data that we have so far. It's really showing us, and of course we have the oral surveillance that is a very well conducted trial. We would rather, and we would love to have another oral surveillance to see whether results are confirmed, but reality is that that will likely not happen, especially if regulatory agencies are not requiring that. These are very difficult to conduct studies, but I think the data we have from oral surveillance is indeed showing to us that especially in older patients, and especially patients who already have ischemic events, that there is a higher risk. So I think we cannot ignore that, and I think it's all about a risk stratification, as you already mentioned. I think we have to find the right patients for the right drugs. And I think it's all about shared decision making as well. And it also influences which type of patient we have in front of us. I think it's very different if it's a patient that is taking a first biological or targeted synthetic DMARD, who is perhaps not so open to risks because there are other options. It's very different, and I can talk from experience. When patients have failed several drugs, they are much more open to taking risks because they're looking for something that works and that helps them to take the disease under control. And this will be a balance between benefits and harms in across patients in terms of patient profile, and within the same patient, what has the patient already had and what is the patient willing to sacrifice. So I think we have to take this into account.
I agree. I agree. I think you hit it well on the head. I think we're going to move on right now to our next section, and that is the modern world of PSA treatment. I like the title of this, Laura. So this is Laura Coates, is associate professor at Oxford and well known for her work in this space. So please take it away.
Lovely. So these are some of the highlights that we identified, particularly in treatment of psoriatic arthritis, ACR. And just one additional disclosure, which is my main highlight of ACR seems to have been coming home with COVID. So I do apologize if I'm coughing a little in between. So the first drug that we are showing data from, and all of these drugs were not brand new. So there was nothing that showed kind of brand new first efficacy data in PSA ACR, but a lot of additional data on some of the more recent therapies that we've had available to us in PSA. So gazelkumab is an IL-23 inhibitor, obviously shows good efficacy for skin and for joints more recently in the Discover-1 and Discover-2 trial. And this was looking at data across 2 years in the phase 3 trial of Discover-2. So this is the largest phase 3 study, and looking across the 6 key domains of psoriatic arthritis, with only one domain missing, and that was the nail disease, and also looking at related conditions of IBD and uveitis. So through this trial, they had around 90% of patients who completed treatment out to week 100, and they looked at response rates across those key domains and saw ongoing evidence of efficacy, ongoing improvement in those different domains. So in the arthritis, the skin, the dactylitis, the enthesitis, and also in terms of axial symptoms as measured by the BASDAI. And obviously the efficacy of IL-23 in axial disease is a very interesting question in PSA at the moment, and one that we're awaiting further specific studies in axial PSA to give us a clear indication. And there was very little in the way of IBD and uveitis as well. So one patient who had IBD and had an exacerbation, and 4 patients with uveitis who had known uveitis and again had an exacerbation. And this is also a drug that's been investigated in IBD as well, so may show efficacy in related conditions. So certainly quite positive data for gazelkamab across different domains, although just this ongoing caution around axial disease and how much we can interpret from an improvement in BASDI in a predominantly peripheral PSA population. It's obviously not something that's specific. Hopefully future studies with MRI imaging will tell us a bit more about whether IL-23 inhibitors do indeed work in the axial disease. And then moving on to deucravacitinib. So this is part of the family, potentially, of JAK inhibitors, but a little bit different. So this drug is a TYK2 inhibitor. That's obviously one of the 4 main types of JAK that we consider, JAK 1, 2, 3, and TYK2. But this is a very selective TYK2 inhibitor, so it doesn't have wider impact on the JAK signaling. This has been tested in phase 2, and we are currently awaiting phase 3 data. So the phase 3 study is ongoing. So this data was looking at data from the phase 2 trials and from phase 3 trials in psoriasis, because this drug was also tested in psoriasis earlier, and really focusing on the safety. So as we mentioned before, we've seen a lot of interest in JAK safety, and I think this extends into the interest in deucravacitinib as to whether this maybe does show similar safety signals to a JAK or not. So in the PSA trial, a lot of patients were on concomitant methotrexate, which obviously may have contributed to any laboratory abnormalities. But the majority of patients really held very strong and stable laboratory parameters throughout the study, with very little clinically meaningful changes in patients treated with deucravacitinib, those who received placebo, or in the psoriasis trials, those who'd had apremilast, because that was a comparator group. There were very low rates of severe or very severe changes in terms of any of the blood results, and the shifts in triglycerides and CPK were very infrequent as well. So overall, this does seem to suggest that the typical changes that we see with JAK 1, 2, or 3 inhibitors are maybe less likely in patients treated with deucravacitinib, a TYK2 inhibitor. We saw a couple of abstracts looking at risankizumab. So this is an IL-23 inhibitor similar to gazelkamab, and is a treatment already approved for use in psoriatic arthritis, and indeed that came from psoriasis before. And this is looking at ongoing outcomes. So there have been 2 large phase 3 trials, KEEPSAKE 1 and KEEPSAKE 2, which looked at the efficacy of risankizumab in PSA. And this study combined data from those studies and looked at long-term efficacies out to 52 weeks. And perhaps as we'd expect, there was good maintenance of response out to week 52. And then when this group was combined, it's probably still underpowered to split into these subgroups, but they looked at whether any obvious signals in terms of moderators of response. So whether there was a difference in response for age, sex, race, BMI, duration of disease, DMARDs, and prior use of biologics. And no strong signals there, maybe some small numerical differences, but nothing huge, still showing evidence of efficacy in all of those different subgroups. And again, perhaps as we'd expect, those patients who switch from placebo onto active treatment also seem to achieve quite good outcomes. So reassuring slightly longer term data on risankizumab. And then this is another abstract on risankizumab, this time out to week 100 in the KEEPSAKE 1 and KEEPSAKE 2 trials. And you can see here again, ongoing maintenance of response in terms of ACR 20 and PASI 90. Sorry, but also across multiple domains.
If it becomes very difficult for you, we can go to Axial SPA and then come back if you prefer. Right.
Let me see how we're doing. So again, we've got maintenance of response here with risankizumab across multiple domains. So the arthritis, the skin, enthesitis and dactylitis. And again, quite well tolerated with low adverse event issues highlighted in both of these subgroups. What I might do is just ask if we can switch to Axial SPA after this one with risankizumab, and then we'll come back to the second half of mine after that, if that's all right.
Lovely.
Prav, are you able to skip through?
Yes, no problem.
We give Laura extra credit for this, above and beyond all
Definitely.
efforts here, and there's so much empathy, having had breakthrough COVID last year, and it's not fun, but you're going to do great.
Okay, so to give Laura a bit of a break, maybe I can continue now with the update on Axial SPA. So in this ACR, we have had the presentation of the update of the ASAS recommendations for the management of axial spondyloarthritis, through which I will want to go briefly, to not go too much into detail and to still go through other highlights and abstracts. So these are the 5 overarching principles of these recommendations that are unchanged compared to the previous version of the recommendations, and therefore I will not go into detail. And after these 5 overarching principles, we formulated 15 recommendations. I will not go through the recommendations as they are formulated, but I will guide you through the treatment algorithm in which we reflect the recommendations. So it starts with the clinical diagnosis of axial SPA, which seems obvious because we're talking about axial SPA, but nevertheless, the task force felt it was important to emphasize this, to emphasize that we really, before we start thinking about treatment, it's good to think whether we have the correct diagnosis in the patient in front of us, and to emphasize that we're talking about a clinical diagnosis, so we're not talking about fulfillment of classification criteria, as those are for research purposes only. In all patients, we use non-pharmacological treatment, namely education. We recommend regular exercise. We recommend patients to stop smoking when they smoke. And we all consider physiotherapy, particularly if patients do not follow recommendations to exercise. If patients are still symptomatic, the first line of pharmacological treatment are NSAIDs. This is completely unchanged compared to the previous version. If patient responds, they continue. If the patient doesn't respond, then we go to the phase 2 of treatment. And here, before we start in phase 2, then we think about the eligibility of patients for the treatment with biological or targeted synthetic DMARDs. These are slightly changed and updated compared to last time, because now we have added targeted synthetic DMARDs. Again, this eligibility criteria start with the diagnosis of axial SPA for the same reasons I mentioned to you before. Then we look at the presence of factors that are prognostic of good response, namely the presence of an elevated CRP or the presence of inflammation on the MRI of the SI joints. Eventually, a radiographic sacroiliitis can be sufficient as another sign present, although radiographic sacroiliitis is not prognostic of response, but is included as for historical reasons, because first trials were conducted in patients with radiographic axial SPA, so AS, without specifying further signs of inflammation. Patients have a failure of standard treatment, so in all patients at least 2 NSAIDs, and in patients who have predominant peripheral manifestations, 1 local glucocorticoid injection, and usually a therapeutic trial with sulfasalazine. The patients have high disease activity if they have an ASDAS of at least 2.1. This is a novelty of these recommendations, because for the first time we recommend to define eligibility for treatment solely based on the ASDAS. And this because throughout the last decade, we have seen extensive evidence that the ASDAS outperforms the BASTAI for several reasons, and therefore it's time to use the most suitable criteria to identify patients suitable for treatment. And then continuing, so if patients fulfill the eligibility criteria and if they have persistent active disease, then the recommendation is to start either a TNF inhibitor, IL-17 inhibitor, or JAK inhibitor, so all drug classes can potentially be started, although the task force felt important to recommend and to emphasize that the current practice is to start a TNF inhibitor or IL-17 inhibitor, and this because there is more data and more experience accumulated with these drug classes, also more safety data and known. And on the other hand, from JAK inhibitors, we have only data from a short period of time of patients in trials. And we also have the safety signals that we have just discussed, that we heard from rheumatoid arthritis and from oral surveillance. And although those signals are not seen in terms of the trials that have not been designed to look at safety in axial SPA, we don't know whether it also applies in axial SPA, and therefore we recommend some word of caution there. A new recommendation on the presence of extramusculoskeletal manifestations, as this can guide the treatment choice, as we know that in patients who have a recurrent uveitis or active IBD, monoclonal antibodies against TNF are more efficacious, and therefore they are recommended. In the case of significant psoriasis, IL-17 inhibitors are preferred, as these have been shown in PSA to have a better efficacy on skin outcomes, particularly on skin outcomes compared to TNF inhibitors. And therefore, in the absence of head-to-head data in axial SPA, we borrow this evidence from PSA and therefore make this recommendation. After at least 12 weeks of treatment, it's good to reevaluate our patients, and we hope to see an improvement of at least 1.1 points in the ASDAS. Again, this is a novelty in these recommendations, that it's for the first time only recommended to assess the improvement based on the ASDAS here, together, of course, always with the positive rheumatologist opinion to continue. And if the patient is responding, then we continue with treatment. And if not, then before moving to the next phase, or while moving to the next phase, but before immediately switching to other treatments, task force recommends to reevaluate whether the diagnosis is correct, or whether there is a presence of comorbidities such as fibromyalgia or osteoarthritis that are contributing to a higher assessment of perceived disease activity, and therefore not having a clear response to treatment before simply moving forward and switching. This is just good to stop and reconsider. And this was not based on evidence, but on clinical practice, but was felt something that we all recognize from daily clinical practice. If active axial SPA is confirmed, then the recommendation is to switch, and any other biological DMARD or JAK inhibitor can be used to switch into. There is not evidence yet of all the switches between all the drug classes, but it was perceived that it's only the lack of studies, and most likely these drugs will act in the presence of failure to one of the previous drug classes. Again, we reassess efficacy after 12 weeks. If we see efficacy, we continue. If not, the recommendation to switch again. When patients achieve a state of sustained remission, then the recommendation is to consider biological DMARD tapering. Here, nothing is mentioned on JAK inhibitors, simply because there is no data yet, so the task force felt it was too early to recommend tapering JAK inhibitors. And this was, in a nutshell, the update of the recommendations. And now I will go through several of the highlights of this Congress, as there were important studies in the area of axSpA that were presented. Here is the first one, the SURPASS study, the first head-to-head trial that we have in axSpA. At the same time, also the first trial that has a structural outcome as the primary endpoint. So patients on secukinumab were compared to patients on adalimumab, and the primary endpoint was no progression of structural damage during 2 years. After 2 years, if we compare these groups, and there were 2 dosages of secukinumab, so with 150 milligrams, there were 66% of no progressors, with 300 milligrams, 66.9, and with adalimumab, 65.6. So no differences across these groups. If we look at mean progression from baseline, mean progression of 0.4 MSAS units in secukinumab 150 milligrams, 0.55 for 300 milligram, and 0.72 for adalimumab. This MSAS progressions are actually relatively low. Unfortunately, it is impossible to have a placebo arm for ethical reasons. We cannot leave patients untreated for 2 years, and we cannot measure progression with the current instruments over a shorter period of time. But still, from experience that we have and from comparing from previous data, these are quite low progression rates, especially if we think that this trial was enriched in patients with a higher likelihood of progression. All patients had either syndesmophytes or a high CRP, which are all known factors or predictors of progression. And nevertheless, we see a low progression, and this reinforces what we have seen before, although from observational studies only, as from trials, it's very difficult when we cannot have comparisons with placebo, but we are seeing that the radiographic progression seems to be low with biological DMARDs, and here we see that it is equally low between TNF inhibitors and IL-17 inhibitors. If we continue now, we move to IL-17 inhibition, another one, bimekizumab. So this is a dual inhibition of IL-17A and F. The phase 3 of bimekizumab in axSpA was presented in this year for the first time. The main data or the primary outcomes had already, like in this abstract, had already been presented at EULAR, but were again presented at ACR, and it's good to remind that. So this is the B-Mobile 2 study. Patients were included with active radiographic axSpA. This abstract, we have data up to week 24, and we see that the primary endpoint at week 16, which was ASAS 40, was met 45% for bimekizumab and 23% for placebo, with a consistent response across patients who were TNF inhibitor naive and who were TNF inhibitor insufficient responders. And we also see response in all other outcomes, namely inflammation as assessed on MRI, with CRP and other domains like function and global functioning of patient and overall health. The same we have seen in non-radiographic axSpA. So this is the B-Mobile 1 study in patients with non-radiographic axSpA, as according to what is usually performed. Patients were included if they had positive MRI of the SI joints or high CRP. And we see that the primary endpoint, again, ASAS 40 at week 16 was met. Also a similar magnitude, 48% in bimekizumab and 21% in placebo. Response was similarly also rapid, already seen after a few weeks after randomization, and also with a response measured in other outcomes of disease activity, suppression of inflammation of MRI, CRP, functional outcomes, and patient-reported outcomes. Now at ACR, and for the first time, we have seen 52-week data. So we now have the extension, and now the results are presented from both trials together. We see that a high proportion of patients were kept in the study. Almost 90% of patients were completed week 52. And we see that efficacy was sustained to week 52. So if we look at ASAS 40 response in bimekizumab patients, they increased from week 16 in non-radiographic axial SPA 48% until week 52, 61%, and the same happened in radiographic axial SPA. And we also see that in patients that were initially randomized to placebo, when they were switched to bimekizumab, they quickly gained response, like in patients that were similarly initially randomized to bimekizumab. So we can see that there is a sustained response in different outcomes in disease activity, also function, quality of life, suppression of inflammation on MRI up to week 52. Also, now my slide is not passing, I don't know why, so maybe someone can help me to pass the, thank you. So also for the first time presented now ACR, at ACR we see the effect of bimekizumab in the same two trials presented combined on patient-reported outcomes at week 52, and we see an improvement in total spinal pain at night, and in stiffness. So in several patient-reported outcomes compared to placebo. Next slide, please, in case this does not work. Now we move to JAK inhibitors, also in axial SPA. First abstracts here are on tofacitinib. Main data of this trial had earlier been presented. And here we have a post-hoc analysis by baseline BMI. And why? Because there is previous literature showing that higher BMI is associated with the reduced response to TNF inhibitors in patients with radiographic axial SPA. And therefore here, authors looked into response to tofacitinib in the phase 3 trial according to the BMI categories. And we see actually that there is no difference in terms of response according to the different categories. So irrespective of BMI, we see similar responses in the different groups of categories of BMI. There were slightly more adverse events in patients with a BMI below 25 kilogram per square meter. And as usual, or as we usually see, regardless of this post-hoc analysis, most frequent adverse events are upper respiratory tract infections. Next, please. Also in tofacitinib, here also a post-hoc analysis, now not by baseline BMI, but by prior BD-MART treatments. So patients, whether patients had been treated before with biological DMART or whether they were naive. And what we can see is that there is improvement in response and in response measures in both groups. So in patients with tofacitinib and with placebo, but where the response is greater in the tofacitinib group. However, here we are mostly interested in the comparison between those that were BD-MART naive and those that were BD-MART experienced, and the magnitude of the difference was similar in both groups. Nevertheless, as we would expect, the response, absolute response, is higher in patients that are naive to BD-MARTs compared to patients that have been exposed. So if we look at ASAS 20, we have a response of 60% in BD-MART naive and about 40% in patients who have, as 40% in patients who are insufficient responders. So we have some difference in magnitude, but still always a higher efficacy of tofacitinib compared to placebo. Next, please. Now we continue in JAK inhibitors, but we move to upadacitinib, and we have a very similar analysis to the one I have just shown you. So also looking at the efficacy of upadacitinib in patients that have had prior biologic therapy. Here it's a select axis 2, it's a phase 3 trial. And this trial was specifically conducted in patients with radiographic axial SPA who had failed a previous biological DMART, either due to inadequate response or, actually based due to inadequate response to a previous BD-MART, some patients also due to toxicity. And what we see here is that groups were compared. And this is only a poster and only a virtual poster. So we do not have more data than what we are showing here. And we see that there is a higher response in the upadacitinib compared to placebo, and the difference range, and we're talking about difference, we're talking about difference between those that had one biologic before or two biologics before, because here all the patients had been exposed to biologics before. Patients were also compared across mode of action, whether the previous biologic was a TNF inhibitor or an IL-17 inhibitor, or whether patients had had intolerance to the previous biologic or they had had a lack of efficacy. And when the groups were compared, there was always a higher response in the upadacitinib compared to placebo, and with different ranges across the subgroups that were between 22 to 33% when we're talking about ASAS 40. Same differences were seen in the other outcomes. However, here we do not have absolute responses. We have differences in responses between those, for example, that had one biologic DMARD before or two biologic DMARDs before, but we do not have absolute responses. It's probably the case that the absolute responses are still higher in patients that had failed one biological DMARD compared to two biological DMARDs, as we know from our daily clinical practice. Nevertheless, we see improved efficacy with upadacitinib compared to placebo across all evaluated subgroups of patients with an inadequate response to biological DMARDs. And I think this is very, very, very relevant information, as we are for the first time, for example, seeing in a trial response to another drug in patients that have failed IL-17 inhibitors. Up to now, all the other trials included only patients failing TNF inhibitors. Also, another post-hoc analysis of the same upadacitinib trial, the SELECT Axis 2, and this is looking at this into the sub-study with non-radiographic axial SPA, in which patients were included if they had objective signs of inflammation, so either an elevated CRP or MRI SI joint inflammation, or both. And here what this abstract is doing is this analysis looking at the efficacy according to these different groups. So by definition, we could not have a group of patients that have CRP negative and MRI negative, because at least one of them had to be positive. So we have three groups. And you can see on the graph on the right-hand side, so the left graph shows ASAS 40, so the primary endpoint. And we see that the first bars are all patients combined. And then we move to the group with positive CRP and MRI negative, where we see an amplitude or a magnitude of response of almost 18% difference between the groups. Then if we move to the next one, is both signs positive, so both CRP positive and MRI positive. Here we see the biggest response, a 44% difference between placebo and upadacitinib, the one I just mentioned before. So CRP positive is the next one, and the lowest one is the one only with MRI positive. We see a similar result on the graph on the right with ASAS low disease activity. And this is reinforcing, this is actually what I just showed you before in terms of prognostic factors that are included also in the treatment recommendations. So we look at, when we are starting a patient on a biological or targeted synthetic DMARD, we look for the presence of factors that are predictors of response, where the presence of CRP is the one that predicts the most response, and then followed by MRI inflammation. And of course, both together predict even a higher response. And here we see upadacitinib improving outcomes compared to placebo in all subgroups. And last slides on another IL-17 inhibitor, izokizumab. And here it's an analysis looking at the efficacy and improvement in patient-reported outcomes in patients that achieve a clinically important pain night reduction. So this was a post-hoc analysis of the COAST-V trial. So it's the trial with active patients with radiographic axial SPA who were biological DMARD naive. And here we saw that a greater proportion of patients achieved significant improvement in spinal pain at night, which was defined as at least 2 points improvement. And this was a high response compared to placebo, so 63% with izokizumab compared to 32% with placebo. And improve was sustained up to week 52. And this achievement of an important improvement in spinal pain at night was associated with improvement in PROs, including the BASFI, fatigue, sleep quality, SF36 at week 16, and also achieving a low disease activity at week 52. And the last slide also on izokizumab. This is a withdrawal trial. So patients that were included initially in both trials for radiographic and non-radiographic AXSpA, they were then followed up, and when patients had achieved low disease activity, persistent low disease activity, they were randomized to continue on izokizumab or to discontinue it, to stop it. And this is the subsequent analysis looking not at the withdrawals, but then if patients have withdrawn and have had a flare, when we treat them again, do they recapture the response they had? And I think this has a very important message for daily clinical practice, as we see that of the patients from placebo that experienced a flare, we see that 14% recaptured low disease activity even before they were treated with izokizumab. So when they were on placebo, there was a decision to switch them to izokizumab, but even before they got the izokizumab, they were already in low disease activity again. And 82% recaptured low disease activity. And a part of those, so 23 out of 28 patients recaptured low disease activity, and 19 out of the 28 met inactive disease. This means that actually almost all patients had a very good response when treatment was recaptured if they got a flare when they were withdrawn. This allows us to be reassured that when restarting treatment, if patients flare and if we have withdrawn them for treatment, there is a high likelihood of achieving response again. And it's good also to emphasize that the design of this trial is withdrawal of biologic, but that's actually not what we recommend and not what we mainly do in clinical practice. We discontinue, we taper, and that makes it even less likely that patients flare. But if they do flare, I think it's very good to be able to tell patients and to know for ourselves that a very good treatment target can be achieved again if we treat patients. And this was my last slide. So I don't know if perhaps it's better to continue to Laura and then have questions in the end, if everyone agrees, if our chair agrees.
Yeah, why don't we just talk about what you just presented, Sophia, and then
That's also fine.
And then we can finish up to keep things compartmentalized.
Okay, perfect.
A great group of abstracts, and thanks for going through the guidelines. I would like to ask, actually, I would like to ask a practical question. Patients with SPA of any sort that have high CRP, that's kind of like the low-hanging fruit. And those patients, it's a very good biomarker for response. So you as an expert and see these patients all the time, what is your approach? How does your approach differ in people that have normal CRPs? What is in your head when you're?
That's a very good question. Thank you. Yes, what is in my head? I think I always want to, first I measure disease activity and I look at the ASDAS, and and then I look critically at the reason why an ASDAS is eventually higher or lower, and I want to try to understand it. So I ask patients questions about possible sources of inflammation, and there I'm looking at axial involvement, of course, but AXSpA is a very, very heterogeneous disease, so I'm also looking at peripheral involvement, any extra musculoskeletal manifestations. So I think it's my duty in daily clinical practice to proactively look to the possible presence of those manifestations. So that's the first thing to do. And the other thing is that actual involvement is not always easy to know. Back pain is a very common symptom. So a lot of patients have back pain, and it's not always easy to know whether back pain is due to axial SPA or due to something else. I don't recommend widely and persistently continuously performing MRIs. I don't think it's always necessary. Sometimes it's straightforward. Either the patient has high CRP, as you just mentioned, or I'm very convinced the patient has really inflammatory characteristics of the presentation with a very high ASDAS, and I'm convinced about it. If I'm in doubt, then I use an MRI. I think that's where the MRI can help us to, when in doubt about whether there is presence of inflammation or not, then to perform, particularly in the patients with low CRP. Does that answer your question?
Yes, I'm actually, I'm personally more curious about those people, of what other dimensions in their quality of life is driving them to the rheumatologist's office. I mean, it may be dominated by pain. There may be other adjunctive quality of life decrements ranging from fatigability or functionality, et cetera. And I think that's, an area for good doctoring.
Definitely. And even within the pain, there are also other sources of pain, as we know. And especially for back pain, it's very important to think about osteoarthritis, fibromyalgia, any other sources that can contribute. So that's why I think we have to proactively try to disentangle what is from inflammatory nature and where biological and targeted synthetic DMARDs can make a difference, or what's another source of pain. And for that, biological and targeted synthetic DMARDs will not really help.
Laura, do you have any comments for Sophia, or questions, or we're ready to get back to you?
Yeah, no, I think I'd agree. I think those are the patients that are tricky in psoriatic arthritis. They're probably the majority of our patients. We often don't see a B27, we often don't see a CRB, and the presence or absence of axial disease can be really hard to identify, even in somebody who has peripheral PSA. And that's one of the biggest decisions we need to make when we're choosing therapy, whether we go for methotrexate first or go straight to a biologic in the case of significant axial disease. And I think often there's more than one treatment that we need to be offering. So we might be thinking about a biologic, but also thinking about physiotherapy and other support to try and help with those other issues. Because I think often there's a mix, particularly in our PSA patients who tend to be older. They probably do have some osteoarthritis as well, even if they do have axial disease. So often is really, really complicated at a single patient level.
Great.
Yeah, I think that's a very good point, and totally agree, Laura. And that's also important to emphasize, because especially when we talk about recommendations, we tend to talk about pharmacological treatment only because that's where there is progress and there is new evidence. But it's really important to emphasize, and I really do it very often. And I think I just mentioned that in the presentation of the recommendations, that really non-pharmacological treatment is very important, and we should give it to all patients. So it's not one or the other, but non-pharmacological to all. And on top of that, then comes the rest. So totally agree with you.
Yeah, there was a lot of discussion because of the ACR recent release of their guidelines for integrative therapies for RA, but I've heard a lot of discussion about that from this meeting. But I think it's a topic of discussion for all of our immune-mediated diseases, and certainly something that merits a lot of critical thinking, and hopefully we'll be generating more data as we move ahead. I think we're going to skip right back to Laura. Laura, just pace yourself here, and we're with you.
Perfect. So this flows beautifully, because actually we've gone from ixekizumab in Axial SPA back to ixekizumab across multiple diseases here. So data from psoriasis, PSA, AS, and non-radiographic axSpA. So this is a really big study bringing together all of the safety data in patients in trials, either over 5 years from the psoriasis trials or 3 years from the rheumatology trials, and showing a very consistent long-term safety outcomes for ixekizumab, which is very positive, really, as you'd expect. some episodes of infection, the most common being upper respiratory tract infection, relatively low rates of serious infection, obviously some candida with IL-17, but not particularly high levels, and quite low rates of opportunistic infections. In cases of IBD, exacerbation were uncommon, and obviously taking into account that this is trial data. So there's going to be a slight difference in data from real world practice. I'm fairly sure over time that we've been a little bit more cautious in who we put into trials in general. And for example, those with inflammatory bowel disease into trials with IL-17, where we probably see lower risk patients going into these studies. We've got some data here at ACR, which followed on from EULAR, looking at outcomes with a new drug called izokibep. So this is another anti-IL-17 therapy like secukinumab and ixekizumab, but it's a different sort of molecule. So it's a fusion protein. It has a very small molecular size, much smaller than the standard antibodies that we see, and has an attachment to albumin, which has been suggested that it may help to penetrate tissue better in terms of treatment of spondyloarthritis. So this is data from an early phase 2 study. There is a phase 3 study and further studies planned. But this certainly showed evidence of efficacy as we'd expect for an IL-17, really. So significant benefit at ACR 50, which was the primary outcome. We're now seeing this shift from ACR 20 to ACR 50 as primary outcome in PSA, which I think is a positive move. And you can see here good response rates really for ACR 50 at around half of the population treated with active drug, and achievement of MDA at around 40%, which at week 16 is really quite good. Often it will take a little bit longer to achieve a good outcome like minimal disease activity. As you'd expect, good response rates in terms of skin. This is an IL-17 therapy, and you can see very high rates, over 80%, achieving a PASI 75. And the adverse event rates were mostly similar to placebo. Obviously, this is a small and a short clinical trial, but consistent with what we'd expect for an IL-17 inhibitor. So I think this is another IL-17 that's likely to come through to the clinic if the phase 3 data goes well. And it will be interesting to see whether there is a significant clinical difference in the response because of this different type of molecule, or whether this will look more similar to the existing IL-17A antibodies. There was also data on upadacitinib. So we've seen approval for upadacitinib in psoriatic arthritis. And this is data from the SELECT PSA-2 trial, where patients had previously failed a TNF inhibitor. And I think just as you saw in the axSpA guidelines, and as we discussed with the rheumatoid data, it's likely that a lot of patients being treated with a JAK inhibitor are probably more likely to be second line or beyond because of these issues about safety. And so this is a really useful population, I think, for us to look at the outcomes. And because this was a more modern study, happened in quite recent years, the inclusion criteria were probably a little bit more relaxed than we've seen before. So this study allowed patients who'd failed up to 3 different TNF inhibitors to come into the trial. And we still saw about half who'd only been exposed to 1 TNF, but a quarter who'd had 2 TNFs, and 17% who'd had 3 different TNFs before. So I think they're the kind of populations that we do struggle with in clinic and that we do need further data for. And this was really positive that across the trial and across different efficacy endpoints, there seemed to be quite similar responses in patients who'd had prior exposure to 1, 2, or all 3 TNF inhibitors. And it's relatively small numbers. Obviously, the study is not powered to compare these different groups, but I think it's really positive that we don't see a kind of obvious difference with lower response rates in people who failed at multiple TNFs. So this supports the use of upadacitinib, potentially in that group where we're more likely to use it, who've had exposure to a TNF inhibitor before. And then finally, to mention bimekizumab, you saw some of the data from the axSpA trials presented by Sophia. Bimekizumab, again, is another different IL-17 inhibitor. So a bit like izokibep, it's also working on IL-17, but this time, rather than being an IL-17A inhibitor, it's inhibiting two different isoforms of IL-17A, IL-17, IL-17A and F. And there's been a lot of very useful preclinical data presented looking at why that might make a difference. There's quite an abundance, particularly of IL-17F in the skin. So it seems logical that this would be more efficacious in the skin. And the question has been whether this would also translate to better outcomes in the joints from blocking two different forms of IL-17. So this is data from 52 weeks in the phase 3 trial. So a kind of 1-year extension to that original phase 3 study. And in this study, those who were biologic DMARD naive, they were randomized to placebo or bimekizumab, as you'd expect, but there was also an internal adalimumab reference arm, which gives us a nice comparator group in the study. You can see here there's good maintenance of response with ACR 50, which again was the primary outcome in the original phase 3 trials, with over half of the patients achieving and maintaining MDA, both in the bimekizumab groups, but also with adalimumab as well. As you'd expect, better outcomes for skin compared to adalimumab in the psoriasis patients, but good levels of minimal disease activity across all of the groups as well. So I think this gives us good longer-term data with bimekizumab. I think there's still a question. Clearly, it's an effective therapy. It seems to behave a lot like the other IL-17 inhibitors. Safety data was quite similar to the other IL-17 inhibitors. I think probably our big question moving forward is whether blocking IL-17F gives us a significant benefit, at least in the rheumatological manifestations of the disease. This appears to be roughly in the ballpark of what we'd expect for a standard IL-17A inhibitor, but obviously we haven't got head-to-head data comparing it to other active therapies at the moment. So it'd be interesting to see in the longer term if we do get some head-to-head studies that show any more insight into how this compares against other active therapies. So that's the summary of the PSA studies. Okay. I think there was one question that came in earlier about the Discover trials. So I mentioned the two studies looking at guselkumab and the data across the multiple domains, and that was just about nail evaluation. So there was no data on nail disease in the Discover studies. That's why it wasn't included in that post hoc analysis. I don't think that was any particular cunning reason, other than that there's just a lot of outcomes included in most PSA clinical trials. There's a lot for the clinicians and the patients to wade through. And I think they made just a sensible decision not to include nail data there. There is good data for nails with guselkumab from the psoriasis studies, from the dermatology studies. So we do have data showing that it works in nail disease. It just happened to not be evaluated in those trials. And I think that was just burden of outcome measures included.
I'll follow up with that. And so if you see a patient that their dermatologic manifestations have significant nail disease, let's just say that's their greatest concern, does that steer you to one drug or another, or send them?
Yeah, so I think nail disease can be absolutely horrible. I mean, we see higher rates of nail disease in our patients with PSA generally. And for the most part, that's, a bit of pitting, a bit of onycholysis. It's not the end of the world. But there are those small number of patients who have really, really impactful nail disease for whom it really impairs their day-to-day function because they can't get something out of their bag or grip something because the nail's falling off. Not to mention, obviously, the cosmetic impact when you're meeting people and shaking hands. So it can be a massive issue for a small number of our patients. And I think in those situations, I would generally go for any of the newer drugs that have been shown to be better for skin. So I think the data for nails pretty much mirrors that in the skin. There's a bit of a difference in terms of which trials have been done. Some companies have done better nail studies. Some people have done better plaque psoriasis studies or genital psoriasis studies, or so lots of people are kind of looking at the more unusual types of psoriasis or sites of special interest. But generally speaking, I think using one of the more effective mode of action drugs rather than a TNF is probably a good option in those cases. And obviously, ideally, you want something that works quickly, but with nails, that always takes time. You don't get a magic quick fix for nails because they have got to grow out.
And just to follow up a question about one other domain that we don't talk about as much in these trials. What about patients that are really concerned or bothered with dactylitis? Does that influence you and how you commence your therapies or approach these patients?
Yes, I'd love to say it did, and I have to say I'm not sure it does because I'm not sure there's great data comparing them. Dactylitis is nearly always a secondary outcome in the trials. It's therefore always underpowered because it's usually present in about 20 to 30% of patients. So we've got quite limited data. We've seen, I think, one study which looked at dactylitis as a primary outcome. So we're still lacking good quality data. And unlike in skin and nails, we haven't got anything that suggests better efficacy for one drug over another. In those situations, I would happily use a TNF first line. I think they have good data for dactylitis. Some of the older trials didn't measure it particularly well, but there are newer studies showing good data for dactylitis, for example, with the older TNF inhibitors like adalimumab. I would probably use something like a TNF over and above a drug like IL-23, which can sometimes be a little bit slow to respond, to try and relieve that quickly. And if I can, and obviously I'm restricted in the UK in terms of access, but I would try and get somebody onto a biologic relatively quickly, particularly if they've got significant dactylitis.
What about local regional therapy for dactylitis if it's just, single digit, et cetera?
Yeah, so single digit, we do a number of different injections, sometimes into the MCP or MTP, sometimes into the flexor tendon sheath, and we can do that under imaging. That can be quite helpful for a quick response. Quite a lot of my patients with bad dactylitis tend to have manual jobs. That's really difficult. Have a lot of plumbers and electricians and people like that who are pulling cabling through houses and obviously using their fingers a lot, which can make it difficult.
Sophia, any comments?
Yes, I was thinking that it's fantastic to see so many, new drugs also in AxSpA, in PSA, that opens up many opportunities for our patients. And I think now we are looking more into knowing who are the right patients for the right drug. As we talked before, I think we also have clarity that if we look at skin outcomes, then if we compare IL-17 inhibition with TNF inhibition, then IL-17 inhibition is more efficacious. But during your presentation, I was already thinking and going to ask you, with even more IL-17 inhibitors in PSA than what we have now in AxSpA, where are we going to, and how are we going to make the difference between them, and are they really different? And my question is, do we think we will get the data now because I'm not seeing any of the sponsors running into head-to-head trials between IL-17 inhibitors. How do we move from here?
Yeah, I think that is going to be tricky. I mean, there's these very interesting suggestions from the basic science that having this albumin binding site, or being a nanobody, or blocking IL-17F might give you additional benefit. But at the end of the day, from the patient point of view, the proof is in the pudding. That what we need to know is actually, does that translate to better quality of life, a better ACR 50, a better BASDAI 50 or ASTAS outcome? And at the moment, I don't think we've got the data to make that judgment. So certainly from the GRAPPA perspective, and when we did the latest recommendations this year, we very much grouped these together as a class and considered them to be the same thing until we have better data, if indeed we do get better data that shows us that there really is a clinical differentiation between them. rather than just a theoretical differentiation.
Great.
Yes, I totally agree with you.
More to talk about after Euler Milan. Hey, I want to thank both of you guys for doing such an excellent job, and Laura gets extra credit for really, doing a yeoman's job here. And we're all sorry to see that you picked up COVID, but we're glad that's Omicron. We know that you're going to do great. I've got a few other friends who, surprisingly, relatively few people came back with it. So maybe it was more the airlines than the meeting. But empathy to you. Sophia, thank you so much for your prescient comments on your space. And we want to thank everybody for listening in. We had great attendance, and hope you enjoyed this. Please fill out that short evaluation. It really helps us craft these in the future. And it's now available on YouTube channel under Cytokine Signaling Forum. So we welcome anything that you have to share with us, so we can make these better as we move ahead. So I think that it's a wrap, and we'll see you after the next go around.